Okay, so the next lecture in the MLA presentation series is head injury. We'll talk specifically about different forms of head injury in individual condition lectures. So we're going to talk about incidents and mechanisms of head injury, how to assess and how you grade severity, how you manage some of these head injuries, and some of the issues you can get after trauma. So head injuries are probably one of the most common things that will come to emergency departments, and there are about 1.4 million people attend A&E, GPs or other emergency settings with a head injury every year. Half to a third are children. Head injuries are much more common in young men than any other group, so mid-teens to mid-20s, and that may be because of sort of risk-taking behaviour. And recovery rates and survival depend very much on how fit the person is beforehand, and any pre-existing conditions, but also on the severity of injury. So in terms of a mechanism of brain injury, you have to imagine that you've got the brain in sort of floating in CSF, you've got the various sort of layers of tissue like the dura, and then you have the skull. So if there is a head injury, for example, to an immobile, unyielding object at the front, then what you'll get is sudden acceleration and deceleration, and the brain within the skull will move accordingly. There will then be rotation on the midbrain and the hypothalamus, which has projections which keep you conscious, and that is what can cause unconsciousness, and that can be quite brief and temporary, and that's when we say that somebody's knocked out. It can be brief if it's less severe, or someone may not lose consciousness at all. These shearing forces can cause disruption to the white and grey matter of the brain. That can be temporary or it can be permanent. And that's probably why we have the sort of post-concussive syndromes that we see, which can be really significant even if there's no apparent injury on imaging. And I just have a little picture here, a diagram of the mechanism of loss of consciousness and the shearing forces that are applied to the brain. So in terms of specific injuries that you can have, in more severe injuries, you can get bruising and bleeding to the parenchyma or the substance of the brain itself, and that's called a contusion or a brain bruise. And that can cause focal neurological injury. It's often in the frontal lobes just because of where injuries tend to happen. And sometimes you can get contra-Q injuries where, you know, you have an injury to the front, for example, and then the brain will sort of ricochet and hit the back of the skull, and then you can get an injury in the back of the skull or the occipital region. You can get bleeding into various parts of the brain and surrounding tissues, such as the epidural and the subdural spaces. That can cause increased pressure and can be life-threatening. Swelling of injured tissue in injured brain, such as after a contusion, can cause raised intracranial pressure, and that can cause something called coning potentially, where the substance of the brain swells so that it can't escape and then it sort of goes down into the spinal cord. And if that affects the autonomic function of the brain stem, which keeps you alive, keeps you breathing, keeps your heart beating, again, that can be life-threatening. And then you might have secondary hypoxic injury. So if there's disruption to the circulation to the brain, either due to the injury itself or due to the degree of swelling, a lack of oxygen can cause further damage. And you may have low blood pressure, either from the head injury or because the rest of the body may be injured in whatever, you know, incident has happened. So for example, a car accident. So if there's injury to the torso or injury to the heart, the blood might not yet reach the brain, and then you might get further damage. So I just have some imaging examples here if you have access to the YouTube video. The first image shows contusions, which is sort of like bleeding within the front of the brain. And the second image shows a subdural hematoma with blood forming a sort of crescent in the subdural space and pushing the brain across. And you can see that the ventricle on the far side is enlarged and the second side is sort of squished against the side of the brain. And in that sort of condition, we would consider neurosurgical decompression. So assessing the level of consciousness after injury. So in Glasgow, forgiveness for that, we have something called the Glasgow Coma Scale. And we use that in acute settings. But remember, you can never have a 0 in the Glasgow Coma Scale. So it assesses eye opening from none to spontaneous, and that's out of 4. Motor response from obeying commands normally to nothing at all, and that's out of 6. And verbal response from orientated to none, and that's out of 5. So normal, orientated, hopefully what I am right now would be 15. And the lowest you can get in the Glasgow Coma Scale is 3. So 3 is extremely concerning. If somebody has a Glasgow Coma Scale of 8 or below, we would expect that they would struggle to maintain their own airway and they should go to an intensive care setting. After a head injury, the received wisdom is if someone is above 12 and that quickly improves, that's a minor head injury. 9 to 12 is moderate and below 9 is severe, but there's obviously, it depends on the situation. So in terms of management, head injury patients need to be assessed by professionals who are trained in acute trauma life support. A factor in someone who's had a road traffic accident or similar is that they may have a neck injury, or they may have broken their neck, which might affect how you perform resuscitation. And they may need to have their neck secured to make sure they don't have spinal cord damage or more spinal cord damage. Respiratory support needs to be assessed on the basis of that, and you would have specialists in critical care who could manage it. CT imaging of the neck as well as the brain might be required, and things like pupillary responses to light and any focal neurological weakness can help indicate early on if there is any intracerebral damage. If there are minor head injuries and people walk into A&E, they may not need any imaging, particularly if there's been no loss of consciousness and they've got normal examination after a short period of observation. But if they have certain things like raccoon eyes, where both eyes are very bruised, battle sign, which is bruising behind the back of the ear, the post-auricular space, or a hematympanium, where they've got blood sort of bulging behind the eardrum, that suggests that they've got a basal skull fracture, and that can cause sudden deterioration or even death. So if any of those features are found, they should have imaging, and you should discuss with your local neurosurgical team. I've just got some pictures of what I've just described. So in terms of treating bleeds in high ICP, which would be a neurosurgical / ITU sort of wheelhouse, in moderate to severe head injuries, you need good ITU support or neurocritical care, good imaging, especially if there are high-risk patients, for example, if it's a high energy impact or if they're on blood thinners. If they've got raised intracranial pressure, you might need to raise the head of the bed, give them mannitol to try and reduce the pressure. And in some people, if the swelling has continued or if they've needed neurosurgery, they might need decompressive craniectomy. So the skull is a closed box. If the brain wants to swell, it's got nowhere to go. So sometimes we take a section of skull to release the pressure and allow the brain to swell until that settles, and then the skull can be rebuilt. If somebody has a severe head injury and needs to be ventilated in ITU, they should have ICP monitoring so that you know what's going on in the head and you know when to image them again in case they rebleed. Forms of intracerebral bleeds, we'll go into more detail in the individual presentations. Epidural hematoma, which you've probably heard about. It's often in young people in sports injuries, and classically it's caused by a hit or a blow by a ball, often in the terion, which is the fusion point between the temporal lobe, the parietal lobe, the temporal bone, the parietal bone, the frontal bone, and the sphenoid. So it's kind of like a junction, and it's quite weak. And if that area is broken, what it can do is it can lacerate the meningeal artery, and you can get a buildup of blood in the epidural space. People tend to be immediately knocked out due to the impact, wake up, so people are reassured, and then as the blood continues to accumulate, they then become unconscious again. They have this lucid period. So that's why people who have a head injury to that area, particularly in a high energy impact, they should be closely assessed by a specialist. Subdural hematoma, so that's crescent-shaped and internal to the bone. It can be due to sort of, again, high-impact trauma, or in the elderly with chronic, often quite minor head injuries. And you get a sort of slow venous ooze, and that can sort of accumulate over time with lots of recurrent falls. And the elderly can then become more confused, decompensated, develop focal weakness, and they may or may not need decompression depending on how fit they would be for surgery. You can get the contusions from direct impact, which we've already talked about, and subarachnoid hemorrhage, which can be spontaneous and then can lead to a head injury, a secondary head injury. And you would, if there is a history of severe headache which then caused a fall, you would think about that and maybe an aneurysm having caused it. But if it is traumatic, there's often a poor prognosis. Risk factors in terms of head injury and guiding treatment are if somebody has a tendency to bleed, and that might be because they're on warfarin or a DOAC, such as a Pixaban, if they're older, if they are elderly, if they present with a low GCS, so if they're unconscious and have been for a period of time, if they have focal neurology when you examine them, if they have seizures, either immediately or following the injury, recurrent vomiting or basal skull fractures, these patients need admitting in the appropriate setting, which is generally ITU or neurosurgery. After head injuries, you can have something called post-concussive syndromes, and they can really affect lives. So it's a constellation of really disabling symptoms such as memory problems, chronic headache, vertigo, depression, anxiety, sensory symptoms. But imaging is normal, neurological examination is normal, and it can take days, weeks, months, or even years to improve. We do know that people have a better outcome if they have written advice and discussion about the fact that after injury you can have symptoms which we would expect to improve. People can benefit from psychological therapies or physiotherapy. It's more likely if people are younger, in female populations, if there are some scan changes and the longer that somebody's unconscious. The other thing to remember in people that have very bad head injuries, and if they're in hospital, if they're slowly rehabbing, lots of fatigue, struggling to engage with physiotherapy, it's worth checking their pituitary function because the pituitary can be damaged after head injury, so correcting any hormone problems can then improve their outcome following. So in summary, head injury is really common. It's most common in young men, presumably because of risk-taking behaviour, and it can cause huge amounts of disability and also symptom burden, even in minor head injuries with post-concussive syndromes. Rehab aims are generally to get people functioning normally in minor head injuries and to have as much independence as possible in moderate or severe head injuries. And there's a role for the neurologist, the neurosurgeon, the critical care team and the rehab team there, and also psychology teams. ICU and neurosurgical management may be required in severe head injuries. Thank you.